Good evening. I would like to thank the organizing committee for inviting me to give this lecture on sharp recanalization and central venous occlusion. I have no disclosures. There are many reasons for central venous occlusions, including thoracic malignancies, infections, and inflammatory processes. Subclavian venous thrombosis as a result of venous thoracic outlet syndrome, but it is frequently associated with the use of indwelling venous devices such as a portacath or permacath for dialysis, or even central lines, especially if they are chronically inserted. And the complications associated with the central venous devices are quite high, roughly between 20 and 30%. Many of them are leading to a total obstruction or a chronic occlusion of the central veins. The majority of these lines are dialysis catheters, and my talk would be about complications of these catheters or obstruction resulted from these catheters, and how to achieve recanalization. In our practice, we use usually the right neck side for insertion of a dialysis catheter. Majority of cases is the internal jugular vein followed by external jugular vein, or even recannulation of the of a previous tunnel if after removal. Left neck, around 7% of the cases, usually internal jugular vein, and rarely the external jugular vein, and very rare is the femoral axis. In order to avoid central occlusion, you have to maintain your axis very well, exhaust one axis site at a time. Exhaust the right internal jugular vein. If not accessible, then the right external jugular vein. Stay on the right side. Check for collaterals, supraclavicular collaterals, cannulation of pre-existing old tunnel, even with the tunnel puncture. Rarely is not a common practice in our institution, the right subclavian vein. Sometimes we recanalize occluded veins on our way to the central axis, and after failure, we can move to another axis, which is the left side usually. Line maintenance is important. So in poorly functioning catheters, we repeat the fibrin sheath angioplasty to reopen the and maintain the axis. If there is a line infection, like sepsis with a tunnel infection, we usually convert the permacath to a temporary dialysis catheter, a Quinton line. Usually avoid converting a femoral Quinton to permacath without checking for neck axis. So you are giving away a prestigious axis if you don't look for the neck axis. And don't remove a permacath without checking a previous venograms to show you if the area is already obstructed or not. So if you're removing it, you are giving up your axis. If we look at the anatomy of the central venous system, the landmarks are the first ribs on both sides, and the thoracic inlet. So that will ultimately include a part of the internal jugular vein, right and left axillary veins, and both brachiocephalic veins, as well as the supra hepatic part of the IVC. The whole region is at the level of C7 to T1 intervertebral disc level. So these are the classification of the occlusions according to the SIR reporting standards of for thoracic central venous obstruction, various types from 1 to 4 to demonstrate the complexity, and is it one side or bilateral? Is it involving the SVC or only brachiocephalic? Usually we are dealing with, if we do sharp recanalization, most of the cases we are dealing with type 3 lesions. So knowing the anatomy is very important, and knowing where is the azygous vein, and is very important to draw a line at this area, because this is the area of the reflection of the pericardial sac. So any perforation above it will result ultimately in a hematothorax, below it in a pericardial effusion, which is, or hemopericardium, which is can end fatally. So this is very important to know the anatomy, study it very well, to check a CT before you attempt to recanalize this area. And this is an illustration of the area. So this is an example of a supraesophagus occlusion. This one is an infraesophagus one. So you are dealing with a dangerous triangle in this area if you are trying to recanalize the SVC. So you have the ascending aorta in front of you and the pulmonary artery behind. So you're moving in a narrow window. Additionally, you have the right atrial appendage. You have to pay attention to it. It can deceive you on a venogram if you have an obstruction of the SVC. So puncturing it or trying to recanalize from this approach will end up in a disaster. So multiple projections and knowing the trajectory of the of your needle is very important to avoid it. For the sharp recanalizations, things are to consider. Symptoms at the end. So you are not treating images. So you check if the patient has SVC syndrome or not. If there is a swelling, there is an indication for your procedure. Otherwise, we are not recanalizing asymptomatic patients unless we have a reason for that, like preparation for transplant. Do we need an access? We don't have another access, and we have to recanalize. This is also a reason in asymptomatic patients. And how extensive is the chronicity of the obstruction? How long is the obstruction? We have alternative options, other side for AV fistula or femoral access surgery or peritoneal dialysis, things to be considered to avoid sharp recanalization. And the goals of recanalization are to treat the symptoms first, so relieve the obstruction and grant and venous inflow and outflow, maintenance of the patency of the vein, or to establish a hemodialysis access, as mentioned. So this is an illustration how it's done if you have bilateral or unilateral, and check for symptoms and proceed accordingly. How to do it, prepare your patient very well. We need to obtain CTA and CT venography as well to check the anatomy. This is crucial for your procedure. You should have all emergency tools available. Stent graft is a mandatory, so you need it for the sharp recanalization. In all my cases, if I do sharp recanalization, I have to put stent graft. Drains, you have to involve the cardiac surgery, or you have to be familiar with pericardial stentesis to place a drain if there is a cardiac tamponade resulting from a hematoma or perforation. You need long access sheaths, large bore sheaths. You need best would be a triaxial system. Crossing catheters, quick cross seeker, These devices are mandatory. Sorry, I had an interruption. Crossing catheters are sometimes mandatory, even O18 crossing catheters like quick cross. Shiva needle, tips, needles, OUTBACK device, snares, plugs, and balloons are required, as well as stents, as I mentioned, as a target, or a snare as a target. RF wire, we're not using it. I'm not familiar with it. I'm not going to talk about it. You need the procedures. The procedure is done under general anesthesia. You need to have backup blood, gain multiple accesses to tackle the occlusion. Use the body floss technique. I'm going to mention it during the cases, through and through a wire. And intraprocedural coagulation is debatable. Usually, I give these patients a shot of 3,000 units of heparin. That can be subject of discussion. Again, these are the tools I mentioned. Roshoshida is a tips needle, a transseptal needle, OUTBACK, RF wire, or surfacer from inside out approach. So always I would start with the standard techniques, not using fancy techniques from the beginning. First line is the standard wire and catheter recanalization. Try to get an access point close to the occlusion from the internal jugular vein, from the arm, femoral access. Try to use the wire only. The benefits are you will stay intraluminal, and the less of the risk of perforation and rupture is less. Limitations. This is not possible in chronic occlusion, not always possible, and especially in long segments, or if you are tackling collateral cannulation. This is an example of a total occlusion on bilateral sides. This was a preparation for venogram, preparation for AV fistula, an 80-year-old male with end-stage renal disease for hemodialysis. The catheter was removed and the patient was planned for fistula, and this is the venogram showing bilateral occlusion. So if you bring the patient in and try to come closer with from venous endovenous approach, you come closer to the occlusion, you'll discover it's a very short distance, and if you get closer to it with wire, you can achieve here with wire and catheter. You can have an access, balloon it, and stent it, and permacath was inserted easily from the right side. The other possibility is to go through the hemodialysis catheter tunnel, which is sometimes removed a couple of weeks or even months ago. So you can try to access it again and do a recanalization from that. This is an example of this case here. The wire was advanced, was going to the azygous vein, was manipulated to the left side, and from there to the right atrium, and permacath was inserted easily. The other possibility is to go through the tunnel if you have an occlusion of the internal jugular vein, like this case. It was punctured, but is leading to nothing. A puncturing of the previous tunnel was successful, and a permacath was inserted through the tunnel without doing any other procedure. You can use the next step. You can use the back end of the wire. Benefits are from this approach. You have a lower profile than needles, and it works usually in short segments. The limitation as mentioned. It's only in short segments. In long segments is difficult to steer, and it will go extraluminal with a high risk of perforation and rupture. You can use the Shiva needle. Shiva needle is 22 gauge, 15 centimeter or 20 centimeter long. You can use it in a braided sheet to avoid puncturing the sheet itself. Ideally for internal jugular vein approach. So you can slightly bend it and direct it in the direction you want to have, get close as possible to the occlusion and align with the SVC and advance it. Best way is to target a balloon or a snare on the other side. So the benefit, the lower profile, these needles are lower profile than other needles, and they are good for short segment. They're not working very well in long segments, likely extraluminal, so the risk of perforation is high. And there is only a slight pending possible, so it's poorly steerable. The other needle is the transseptal needle, which is curved like 45 degrees, which allow maneuvering and better stability, but it is 18 gauge. And requires a 018 wire, and it needs or coming with an angled 8 French sheet. Technical success is 90%, complication rate 5 to 10%. There are already papers published on this technique by Arabia and McDevitt. Here's an example of using the wire for recanalization. PermaCath was removed from the other side because the patient was sent for PermaCath exchange. The wire couldn't pass to exchange it, and the venogram showed this occlusion. We tried to cross from above. It resulted in small extravasation, wasn't possible, so access was gained from the right femoral vein, and we tried to come closer from above and below. Snare was placed, to go back. Snare was placed in from the femoral axis, and with the back end of the wire, the snare was targeted, and the wire was snared. And this is the body floss technique. So the wire was catched with the snare and snared from femoral. And here is the confirmation with the venogram that there is no complication, but we still have the occlusion. Now you can tackle it with balloon first and stent graft. And the technique we are using, and it's very important, use a balloon, a low profile balloon, 3 to 4 millimeter, only to allow the stent to pass from one axis, and from the other axis, I don't know if you can appreciate it, the stent is here, is coming from the upper axis, and the balloon from the femoral axis. Once you dilate it, you pull your balloon and push the stent over it. This is the stent placement and the end result. As you see here, a patent SVC and no complications. So another example of a patient with the right brachiocephalic fistula presented with SVC syndrome. Tried to puncture the PermaCath tunnel, was leading to nothing, only small collaterals. A bilateral arm axis was gained and showed total occlusion, total central occlusion. Have only brachiocephalic vein is patent on both sides. So femoral access was achieved, and as you see here, the left brachiocephalic vein is patent, but the SVC is occluded. So we came close to the occlusion, as you can appreciate here. It's a short distance, and with using the wire with support catheter with seeker catheter, the occlusion was crossed, and the you see it here, no complications, and the wire was catched from using a snare from below, from in the IVC. So a wire floss technique was achieved, as you appreciate here. Balloon was used for dilatation, 7mm balloon, and a stent was placed successfully. Sorry, I have to go back. And the symptoms were resolved. So the patient has no SVC symptoms anymore, but he came later, he came back 3 years later with malfunctioning fistula. The patient has a fistula on the right side, right brachiocephalic fistula, with right upper limb swelling, severe edema. So can appreciate here the occlusion, which we didn't tackle in the first time because it wasn't necessary. Now it is indicated to go for it. And this time we used from the femoral axis a transseptal needle, targeting a snare in the right brachiocephalic vein. The snare, the wire was snared. Again, the flossing technique and balloon angioplasty, and a 14mm stent was placed. And as you see here, nice result with reconstruction of the veins. Shiva needle, this is an example of curbing it, as you can appreciate it here, targeting a snare in the SVC, puncturing it, catching the wire again, and putting a stent. There's another example of doing it using a snare as a target and stent and permacath insertion. The other device is the OUTBACK. I talked about it. The benefits are the device is less traumatic, low profile, 6 French. You can direct your puncture in the way you want, but the limitations are that this needle is a very short needle for long occlusions. It's not a proper device. It has a poor penetration of tough fibrous occlusions. Sometimes you cannot get inside the occlusion with this needle, and the wire can be sheared from because of the sharp needle, and it is usually extraluminal with potential perforation. There's already publications about the use of it. This is an example here of a permacath, which is going to the azygos vein, was removed, and recanalization was done from below, from the femoral axis. As you can appreciate here, the OUTBACK device putting the wire inside the left brachiocephalic vein, catching it from the other axis, and establishing a through and through axis. Again, balloon and stent and permacath reinsertion. There's another case of an occluded, if you can appreciate here, the brachiocephalic stent in the right side. The patient came with SVC syndrome, facial swelling, and he has already a right brachiocephalic stent deployed in 2017. As I mentioned, the stent was nearly occluded here. It was recanalized with a standard technique and ballooned, but the patient had a mild improvement, and persistent bilateral tinnitus and left neck and arm swelling. So he came back again after 1 week, and the procedure was done under general anesthesia, and you can see the long occlusion with the collaterals on the left side. The stent was targeted in this situation. Sheet was brought very close to the stent, and the OUTBACK was used to maneuver the wire inside the stent, and again catched from below, balloon dilatation and stent placement with good result, as you see here. So technical tips to avoid complications are proper alignment of your needle with the target, balloon, catheter, or snare, using multiple projections. If you able to use a cone beam CT, use it to see the anatomy very well. Insert a balloon, as I mentioned, from one axis and a covered stent from the other axis in order to act quickly, and puncture from the lower pressure side against the flow. Here is the, again, demonstration of the balloon from one side and the stent from the other side. That's it. Thank you very much, and I'm happy to receive questions if I'm allowed to be online with you guys.